based on the memoir itself. You have written a memoir, which is not something common for medics in Tanzania to write their memoirs. Could this be a motivating factor to why you wrote the book? Of course, you explained in the foreword why you ended up writing the book, but could this be a factor that sort of motivated you to write a book? Because there is basically so many experts in healthcare in Tanzania who may not have written much about their experiences like you did. Could that be the reason?
No, I mean, the reason is after retirement.
Yes.
So I went to teach in Nairobi, which I have explained. But then after that, when I came to Canada, I was a retired person. And I didn't have much to do. I had all the time. So I thought, let me put down some things. And I realized that I could come up with a lot of messages. In every phase of my life, there is something which I thought was constructive, which could be of tremendous help to the younger generation. So because of those messages, I said, no, let me put these things down in a proper way so that a lot of the younger generation who are aspiring to come into the medical field, for them to understand. So that was one reason. The other reason is my observation while I was in Muhimbili at Muhas was that a lot of doctors who qualified thought that clinical practice is the only way out. I did not join the clinical practice. I went to basic sciences.
True.
Yeah. So you see, there is also a very prolific opportunity within basic sciences to build your career. Now, I was very lucky because I was doing clinical research, like clinical trials in a village setup in Bagamoyo mostly. I was able to put my clinical practice there when I was doing the research. So you can always have a combination of 30% clinical practice and 70% research, or 20% to 80%. But you see, for a medical doctor to understand and perform research is a very important thing, even if he is a clinician. Because the number of patients you treat in your lifetime, they are all data points. So my aim there was to say that research is a very important tool. Whether you are a clinician or you are a basic science expert, but you will only be able to improve the healthcare delivery if you do research.
Indeed. And of course, you've shown how that works practically, and
Exactly,
your words would make sense.
Sure, yeah. I mean, there is a lot of opportunity in the hospital as well as in the community to do research, and specifically healthcare research.
Of course, when it comes to research, maybe briefly about that before I go to my next question. Actually, just as a follow-up on research, there has been this contentious debate about research opportunities. There seems to be a complaint, if I would put it, from among researchers in our country, especially the young researchers, about the opportunities to research. And of course, the word opportunity here can be defined in many ways. And here there is this issue these days called research colonialism, whereby the priorities of what to research on is determined by one with money, it so happens that now most researchers end up being, they have complained that they end up being enrolled as data collectors, and that's, the opportunity to research because their nation is funding research seems to not to work. What's your take on that? If you really get my question.
Exactly, I have understood you very well. One thing is for sure, whoever will fund your research will come up with a research question. Because the important thing in research is, what is the research question? Now, if your funding is coming from USA and your research questioning is also coming from USA, it is definitely not going to be in the context of Tanzania. So that is now research colonialism.
Okay.
Now, but if you can create your own research questions based upon your own curiosity, okay?
Yes.
And I will give you a very small example. If you ask any medical doctor today at Muhimbili, what is the prevalence of scabies in Tanzania? They don't know. They will give you a very rough estimate. We don't know what is the prevalence of scabies. Now, if you ask this question as a young researcher, that I would like to find out what is the prevalence of scabies amongst the school children. Now, you don't need money to go to a school to make a diagnosis of scabies, because when you look at someone's hand, you will know that this is scabies positive or negative. It's a clinical diagnosis. That research should not take you more than 3 months without a single penny, but you will come up with some very good information. Okay,
indeed, that's true.
So let's say if you are a medical doctor in Morogoro, you can easily come up in a very short period of time with the answer that the prevalence of scabies in school-going children in Morogoro is this. Now, from there, a lot of other issues come in, because scabies is a water-based disease. Okay, wherever there is shortage of water and all that, you will have scabies. Now, why is there prevalence in one part of the region compared to another part? So then you will ask yourself, is there water availability? So you see, it all depends upon the commitment. It depends upon what research questions you are asking. Now, the most important part, how is the senior faculty at medical universities guiding the younger generation to ask the right questions? Because when you finish medicine as a 5th year and you do your internship, you need to be guided how to ask the right research question. Now, once you have asked the right research question, the rest of the other things will follow, the methodology and all that sort of thing. I see this is missing in our younger generation because they always think that you cannot do research without money. You need millions of dollars to do research. That is what they think, which is not true. You can do research with very little money, available locally, and you can always answer questions that are important within the Tanzanian context. Okay? Now, that is not being done. But another important issue is that research is not properly regulated in Tanzania, especially medical research is not properly regulated. And I will give you an example. When I was at MUHAS, and if I want to do research, clinical research at the Muhimbili National Hospital, I was supposed to go and ask for all these permissions. There was a lot of bureaucracy. And wherever I went, they wanted money. That according to us, we need 10% of your budget as our institutional fees. And I was saying, why do you need this money? I'm not going to use any facility. I'm just going to see patients. And actually, I'm going to help you. And the results will be helpful to the whole Tanzanian health care delivery system, to the ministry, to everybody. So if from Muhimbili, I want to do research at the Temeke District Hospital, now it is a region, I believe. I could not do that. Now, research is not properly regulated. You know?
So it needs to be regulated indeed. Actually, I think that's quite elaborative. And I would actually wish to go back to the book now, because you said in your practice, as your book says, you observed the clash between tradition and modernization, and this is quite important here. And there is what you describe, the iPod and the mullahs. What did you mean here? I would like to hear you speak about what really did you mean by this clash between tradition and modernization? And what exactly did you observe in your practice?
Yeah,
from all this story that we have in the book.
Sure. When I started, and maybe 30 years later, or maybe 40 years later, there was a lot of change within the practice of medicine as well as within the research. Okay? So when I started, we did not have a computer. You see, we were doing research using paper. So digitalization came in. Okay, now things have changed a lot. The information highway is available to you. Now we are talking while you are in Dar es Salaam, I am in Calgary, thousands of kilometers away, and we are talking in real time.
Yeah.
So you see, research has changed. It has become more digitalized. It has become much more convenient. So gathering data, analyzing the data, coming with inferences, the whole aspect of epidemiology, the whole aspect of research methodology has changed. Okay? So when I talk of the iPad, that's what I meant. I meant the issues about digitalization and the use of IT in the practice of medicine and in the implementation of the research work. It is no longer now for someone who says he's a mullah to tell you that, look, this is what is written in the holy book. You don't need that anymore. I mean, the information highway is far ahead of these things, and science has changed the world.
Now I get.
Yeah, so my message there to the younger generation was that as you go into your medical education, you will come up now. You will be in an era of digitalization. Okay, so I went through all these eras. I went through the time when we used to go to the field with a paper and a pencil. And by the time I was ending, and retiring, we were already digitalized. Okay,
Interesting.
So I think the younger generation has a lot of opportunities there. They cannot be digitalized. So that's what I meant.
Yeah, it's quite interesting that you're showing this paradigm, the way things have changed over the years.
Sure.
Yeah.
A lot of changes. But the changes are good.
Yeah, the changes are good. And of course, since you wrote the book and since it was published, some changes have taken place. Your book came out before the WHO announced that it had approved the RTS ASO1 vaccine.
The malaria vaccine.
This is seen as a historic move, and I would like to hear from you in the context of the 5 enigmas of malaria, that complexity of dealing with malaria. Do you see this vaccine as, taking us to where the malaria fight should make us reach? Or do you see this as a game changer, this vaccine?
So before the vaccine was approved, and let me tell you that since the vaccine program started, sometimes in the early 90s, I have been a member, the global member of the independent data monitoring team.
Okay.
Yeah, so I have been in connection with this vaccine for the last 35 years.
Wow.
Since it started, I have been a member of the independent data monitoring team. And this is a global team, which is not part of the vaccine research, but we get all the data. And we were meeting twice a year, sometimes 3 times a year, based upon the data that was coming in, to look at that data, to verify it, and then to give our opinion. So I was involved with this vaccine, the RTS vaccine, right from the start. Okay? Now, before the vaccine started, or before the vaccine was approved, we had reached a stage in malaria control where the use of combination therapy and the use of insecticide-treated nets and the use of indoor spraying had reached a stage where malaria prevalence was declining, even in sub-Saharan Africa, because of all these methods. Okay? Now, the addition of the vaccine, despite the fact that it is only 30% efficacious, which means that out of 10 children who are vaccinated, 3 will be protected. But now, because of the complexities of these diseases, even a 30% protection in an area where there is seasonal malaria, it will be of extreme importance to be part of the control measures.
The challenge here looks like there will be, these are perennial problems in our countries, in Africa especially, with the issue of distribution. It was announced just recently. I think it doesn't have a month, more than a month. It's about a month. When do you think a country like Tanzania, where there are experts who have participated in these trials and all that, when do you think we could start realizing the benefits of this vaccine? And do you see this logistical process of having the vaccine here? Do you think it's something that people should start celebrating at this particular moment? What would you say about this?
So let me tell you that as a scientist, once we discovered 30% protection, that was full for me. Now what happens is the politics of vaccines, the distribution, the procurement, and all that. I'm not part of that, but let me explain to you that it is not a very big issue.
Okay.
And in areas that will need the vaccine, I'm sure global agencies like WHO and other agencies will come forward, because now the world is a very small world. So if there is a malaria outbreak somewhere in Africa, it doesn't mean that that outbreak cannot spread elsewhere.
Mm.
So I have this issue that it may take a bit of time till the dust will settle down, and then the malaria vaccines will be deployed in the real life situation.
Mm.
But I think, as you put your question, we should celebrate.
We should celebrate. Yeah. And it's also difficult actually to escape talking about COVID-19. You know. Of course, you said in the book that the book would not be complete without writing about COVID-19.
Oh.
But you know, there is something interesting here. You issued a strong warning. You know, especially in relationship. You know, you spoke about COVID in relationship with Tanzania, in the context of Tanzania, which is, you know, everything is known about how COVID was handled in Tanzania. But then you issued a very strong warning that the history will judge us, will judge our actions if our intellectual, if the actions we took were intellectually appropriate. And I would love to hear you tell us why you say this. And you actually seem to propose that you know, COVID-19 is another flu that we need to cope with using intelligence and genuine science, and you seem to be a little bit bitter about the science that was used to deal with COVID-19. Is that correct? Are you bitter about the science?
Yes, exactly. So let me explain this. Let me explain this in a very logical way.
Mm.
But let me start by saying that in science, you don't need emotions. When you think emotionally, you will not be able to think scientifically.
Mm.
Now, because of COVID, you know, the whole world started becoming very emotional about it. Rather than sit down and be rational as far as science is concerned. So if you recall, when the epidemic started, when the pandemic started, they were all talking about ventilators, and that patients were coming to the hospital with hypoxia. But nobody was asking how did they get that hypoxia. Okay, now, later on, because of science, we came to realize that the hypoxia was because blood was clotting. And therefore, the blood supply to the lungs, because of coagulation, there was no oxygen. That was the reason.
Mm.
Now, so you see, science has helped us there, that if you don't want hypoxia, you make sure the blood does not clot. If the blood will not clot, then you will not get the crisis of the ventilator. So if you look at science in its proper way, without being emotional, without being political, then I think you will be able to answer the issues. Now we have the vaccine. 1 year back, we never had the vaccines. Now we even have the antiviral drugs that are now coming out. Okay? These are all good scientific discoveries. But if you leave the disease because of emotions to the politicians, the politicians will come up with any statement. Now, the biggest question just now, and I think it is extremely important, why is COVID not hit sub-Saharan Africa as much as it has hit the Northern Hemisphere? Okay? Now, I was listening to a podcast that was actually saying that ivermectin is a very poisonous drug. Now, this is not true. In North America, they are now saying that ivermectin is a very poisonous drug. Millions of doses have been taken by the African population. I was the one who was prescribing ivermectin in all the control programs of lymphatic filariasis, of onchocerciasis, of geohelminths. Our children have taken millions of doses of ivermectin, and nobody has died of ivermectin in Africa. Not a single case. While here now they are saying ivermectin is poisonous. But ivermectin...
Sorry, do you see enough scientific evidence to support the fact that ivermectin would actually be a very good treatment for COVID-19?
Yes, there is evidence. There is evidence, but what we need is more research, more clinical trials to give us the right endpoints. What is the protection that you get from ivermectin when you have the symptoms of COVID-19? Or can you use ivermectin to prevent infection? So there is need to do more research there. I don't deny that. It used to go in veterinary. Now, any medication, if you take outside the recommended doses, it will become toxic. But when we used ivermectin in Africa to treat geohelminths, to treat onchocerciasis, to treat lymphatic filariasis, nobody died. Today, you go to rural Africa, you go to rural Tanzania, the prevalence of hookworm, the prevalence of ascaris is almost zero because of ivermectin. Let the scientists tell you.
You're satisfied with the current approach that is being used against COVID-19 in Tanzania?
Oh yeah, sure, 100%. I think in the last 1 year, the committee that was appointed under Professor Said Aboud, have come up with the right recommendations. So I mean, they are doing the right job. Now the politicians' job is now to ensure those recommendations are taken forward. But to stupidly, just for politicians to gain a popular vote, they come up with their declarations about a scientific disease like COVID, which is killing people.
As a scientist who has worked in Tanzania, sorry, cut you short a bit. You are a scientist who has worked in Tanzania. You know Tanzania very well. I would say from the grassroots, because you've worked in villages. I've read through your book, your life in Mtwara, in Tanga, and Iringa. Of course, in Iringa, you are still young. And of course, you've traveled to many parts of the country. Your relationship with politicians in Bukoba, those dilemmas of dealing with politicians. How did the handling of COVID-19, the kind of denial that was going on in the last 1 year before that committee came up with these recommendations, how did that make you feel as a scientist who has grown up in Tanzania and seen how the country has been handling public health problems? How did that make you feel as a scientist?
I was really sad. It was extremely sad, and I was disappointed. Because when COVID came, the actual government stand was missing. And later on, they said, you go to the church, you go to the mosque, you pray, and COVID will disappear. Now, come on. This is not science. You don't go to the church and pray, or if you go to the mosque and pray, okay, praying will reduce anxiety, but it will not finish the COVID virus, the coronavirus. Okay, so if by praying you can remove COVID, then why don't you pray and remove malaria? I mean, nobody talks about that. But we were not able to question that, look, going into the church does not help the COVID thing. It helps you. It brings some peace in your mind, in your consciousness. It is not bad. It is not harmful to go to the church or to go to the mosque. There is no harm in doing that. I also do that. But when it comes to science, you don't mix these things. You see, and then to come up with these things like the diagnosis was not right, and that the medical team that was doing the diagnosis was fooling. You know, those are not the right sentiments that I would agree with. Okay, if there was a problem in the diagnosis, let's look what was the problem. But you don't take blood from the sheep, or I don't know, from some fruit, to prove that the diagnosis is not right. This is not how we do scientific curiosity. So personally, I was really disappointed. But now, in a country where the rule of law is compromised, in a country where you cannot have the freedom to speak your mind, in a country where you are told what to do and what not to do, these things can happen. So our democracy was compromised. Our democracy did shrink. But now people have come to realize that no, there was some mistake somewhere. So let us go back to the scientists. Now they are turning and they are saying the vaccines are good. Let us get vaccinated, which is good. Let's go to the hospital once you are sick. Okay, so those are the things which are right. But the same people who are today talking about vaccines were one day drinking the Madagascar juice. Now, how do you reconcile that? How do you reconcile that?
But to some degree, when someone reads the book that you wrote about COVID-19, of course, I would have wished that you had dedicated a chapter actually to COVID-19. Unfortunately, it was just a small piece of it and a chapter. Someone would think that you actually support, to some extent, the approach that was used by Tanzania, because it calmed down the people, and you actually didn't support the idea of not locking down the country. You support the idea of not locking down the country. But of course, no country was compelled to lock down its people. You know, somebody would get a sense that you are somehow in support of the approaches that were used by the government by then.
I have been very specific. I supported the government stand as far as panic was concerned. You see, the whole world panicked. People were dying. I mean, doctors had to take decisions in the hospital whom to give the ventilator and not to give a ventilator. So we were in a very difficult situation. People had become very emotional. There was a lot of economic impact. Okay? Now, in that situation, I think the late President John Pombe Magufuli, did the right decision. How to remove that panic. Now, in order to remove that panic, there was no need for a lockdown. Okay? Because in a country like Tanzania, where the economic issue is a very important issue. Now, someone who is selling madafu, he goes out in the morning, whatever he gets by evening, that is his meal. Now, today you are telling him you don't go to sell madafu because the country is under a lockdown. how will he survive with his family?
Yeah, that's really something to think about.
Now, in the rich countries, people were told not to go to work, but they were getting some salary, some percentage of their salary. But in Tanzania, that cannot happen. If you don't work, you don't eat that.
Don't eat, yeah.
Yeah. So the sense of lockdown in the year 2020, March, April, May, that is the time when there was a peak. So what the president did was the right thing, to remove that issue that, look, now this is the last day of your survival. You will die tomorrow. That was not the case. So that panic was removed. So what I have supported is, today in Tanzania, if you go and talk about COVID, people are not afraid. But if you go to Kenya, they are afraid.
Yeah.
Because the panic issue was not...
But that scientifically had implications. For instance, now you see the risk perception of COVID-19 is so low. Initially, so when they tried to introduce vaccines, everybody was saying, why do we need a vaccine? Well, COVID is not an issue.
The panic issue became so, it was stretched so much that now we started talking about the church and the mosque, and that there was a denial, total denial. Now those I don't support, but I agree with you that the present government is now a very big task ahead of convincing people to wear masks, to do social distancing, or maybe to get vaccinated when the vaccines are available. It's a very big task. It is definitely a very big task, but there should be a task force for that sort of work. You need here now medical sociologists, psychologists to come in to advise the government how now to remove what happened in the past. The negative.
Yeah. Yeah.
So I agree with you. I totally agree with you. But today, if you hold someone in Dar es Salaam and asking about the panic issues, they are not afraid.
They are not afraid.
Now compare that with where I am living just now in Canada. It's a very different scenario. Here, people are afraid.
But that also helps them to, if it doesn't create any mental health problem, but it also helps them to, be vigilant and prevent the disease from spreading. Isn't that positive?
Yeah, it is positive. But here now, because of the freedom, that you have freedom to choose. So you see, you can say that I will not take the vaccine. It is my right not to take the vaccine. While in Tanzania, we can resolve those issues very easily.
Yeah.
Which doctor in Tanzania will refuse a vaccine today? To be very realistic, any public health worker, they will not refuse a vaccine.
Yeah, there are actually reports of vaccine hesitancy among health workers here in Tanzania, which have been documented. And of course, some were, totally against the vaccines. There are particular examples. What do you make of that?
I saw one YouTube clip of a specialist doctor, and she was against the vaccine. But as far as I'm concerned, if I was in Tanzania today, and if I was against the vaccine, let's say, I would not go public, because the issue about doctors, they should be resolved within their committees.
Indeed.
And then what comes out of that should be one opinion to the government. So I personally felt that individual doctors who speak about against the vaccine should not come public. They should, first of all, go to MAT and let them resolve their issues there.
Mm-hmm.
That is what I thought.
So going public means that you actually influence the decisions of the majority, whom their behavior towards the pandemic would actually be catastrophic.
Look at the literacy rate in Tanzania as far as medicine is concerned. You have to be literate, and then you should have a highway of information coming into you. How many people in a district can actually open up an internet and get all the information that is needed? It's very little.
But in a country like Tanzania, where people were questioning the efficacy of vaccines and actually interrogating everything that was coming out of the science that was seemingly coming out of from the West, people would say that scientists having their own thoughts and then deciding to keep quiet would be denying the public information. As a scientist,
exactly. You think? I agree with you. I totally agree with you. But whatever comes from the scientific community should not be ambiguous.
Should not be ambiguous. Yeah, indeed. Yeah.
Yeah, they should sit in their room. They should then talk about their antigens, their antibodies, whatever. And then whatever comes to the public is a single statement.
Mm-hmm.
So let them thrash their differences in their own associations.
Mm-hmm.
But what the politicians should be told is one language. And that language should then go to the common man.
Yeah, indeed. Yeah.
Yeah.
And Professor, I'm actually coming to my last question, and I want to focus on the book, actually. A very interesting book indeed. I would like to hear something about your experience at the private medical university in Kenya. That was a touching story indeed. It's a touching part of the story. How you tried to cope with, what you described as corporate toxicity.
Yes.
Yeah, and and how you ended up terminating your contract.
I did not terminate the contract. It came to an end. It was
came
a
to an
3
end.
year.
So it wasn't terminated per se.
No, I did not. They wanted me to continue.
But you resigned.
But I said I don't want, because I was not very happy. I was not very happy. And when you are not happy, at my age, there is no need to suffer.
Sure.
So there was a lot of corporate toxicity. There was definitely, I never agreed a profit margin of 1,000%, sometimes 1,500%.
Yeah.
I don't agree with that. Okay. Especially when they call themselves the non-profit organization. So what was happening in Nairobi is exactly what is happening in Dar es Salaam. My message there is the private medical practice in Tanzania, in Kenya, they are totally not regulated by the Ministry of Health. And I'm also suspecting a lot of corruption there. And why should a penicillin, or let's say ampicillin capsule, cost that much in one private clinic compared to another private clinic? The private practice there is there to supplement. It is there to complement. It is there to help the public health system. It is not doing that. It is actually not treating Tanzanians. It is treating foreigners. It is treating people who are corrupt politicians. It is treating those who are involved in the drugs and all that sort of thing. People with money.
But they would argue that they offer the best quality healthcare, and to offer that you need to have a huge investment, and that comes with exorbitant costs.
Let us define the best quality, the one that they are talking about.
Still, most Tanzanians go for healthcare in that facility, and they flock there, most of them. And of course, there are complaints here and there of the high cost, but many still go. And what the pull factor could be probably that we want to define the best healthcare.
Look, President Magufuli, when he became the president, on the second day or the third day of his presidency, he walked into Muhimbili, and the CT scan was not working. And he was upset about it. The Director General of Muhimbili was immediately suspended. And then we got another director. The public health system is a good system. Nobody refuses that. But we need the private health system also to help us. But the private health system has to be regulated. It is regulated everywhere, globally, even in Canada. We don't have a private healthcare system here. But if there is, it will be regulated. You cannot have a private health system in Tanzania and it is not regulated. Well, this is part of the corruption system in developing countries. Tanzania is not the only thing. It is a corruption.
And, but someone who has read the book here would say that, given your background, you're really in support of socialism, and you support the fact that you were educated in that system where the government.
No. That is not true. I'm not in a socialist country anymore.
Someone would argue that that's why you feel like the corporate toxicity is too much, because of that passion you have for a kind of supportive system for healthcare from a government that is a bit more socialistic than capitalistic. How would you counter-argue that?
In a capitalist system, they make sure that there is no corporate toxicity. In a capitalist system, they want you to be as comfortable as possible. In a capitalistic system, a nurse will not be the boss of a professor of pathology. This is only where corruption, this is only where nepotism can come in. Now, let me explain this. The socialism that I went through during the Nyerere's time has changed. Even today, people like me, we have changed in our attitudes. Socialism does not mean poverty. You can be a good socialist, but still be rich. I studied in Sweden. I know the social medical system in Sweden. In Sweden, you cannot be denied these sort of things. Okay, and they are social democrats. Okay, so the issue here is corruption. And my next book is going to be on corruption. I can assure you that it is coming out.
Okay, interesting.
My next book will be on, you cannot be in Dar es Salaam and suffer TB, and when you go to Muhimbili, you get another protocol of TB treatment and another protocol in a private hospital. I mean, it does not make sense. Yeah, you have to make sure that anybody in Tanzania who suffers from tuberculosis will be treated with the same protocol. Why? Because it is of public health importance, not to mistreat TB. Okay? Now, if you can do that, If you can do that, why can't you regulate the other issues of the private practice? Who is employed in the private practice? What are their qualifications? The issue here is that there is a lot of hesitancy in bringing the private system at the same platform as the public system.
Yeah.
And they are afraid because money is exchanging hands.
Yeah. The politics and the corruption, of course, is very rampant, and it needs to be addressed. It affects public health decisions. That's true. I agree. Professor, please, one last question. I shouldn't, because you are an expert in malaria, it's very difficult to, end this discussion without talking about the impact of COVID-19 on malaria. I would like to, malaria interventions, actually. I would like to hear your word. How do you think COVID-19, of course, there has been a lot of evidence out there that COVID-19 has reversed the efforts in tackling malaria greatly. What's your observation about this? And what do you think should be done going forward? What would be your advice in the way we deal with malaria in times of such pandemics?
So, in those countries where there was outbreak of Ebola, the malaria control in those countries, in Central Africa, they all collapsed. This is about 3-4 years back when there was an Ebola outbreak. There was no malaria control activity. Okay? The same sort of impact is there as far as COVID-19 is concerned, because just now, all the attention is in COVID-19. HIV, malaria, TB, they will all suffer. Obviously, because that is an emergency. COVID-19 is an emergency. Now, as far as I'm concerned, the situation of malaria will definitely regress. So whatever success we had with the control programs, there will be some regression. Because now people will be more worried about the COVID, and there will be more funds towards the COVID. So malaria will definitely suffer, like in Zanzibar. It was about to declare itself as an eliminated zone, but it will not be able to, because there will be small outbreaks. Okay, so definitely there will be an impact on malaria control, especially if there is climate change, because malaria is a very dependent disease on the rainfall pattern. Now, if the rain, there will be excessive rain, then there will be what you say, the mini outbreaks of malaria. Now, malaria is affecting mostly under 5s and pregnant women. While COVID, as we know, the small children have not yet been, we have not documented that as much as it is in those who have comorbidities. Okay? So you see, we are playing with a different age groups. So maybe if the present impetus is maintained and sustained in malaria control activities, the prevalence in under 5s and in pregnant women might not go that high, but definitely there will be some impact. That's what I would say. But then I'm just speculating. I don't have any data.
Yeah, of course, you've been away, and of course, since the pandemic began, you probably have not have had enough hands-on research activities.
Yes,
yeah,
but I think
it's been through reading and
but I think there is now more increased consciousness, and there is more awareness of doing the right diagnosis for malaria.
Oh. At this
Initially,
moment. Why?
Yeah.
Why do you say that?
Initially they were treating every fever as malaria. Now they will want to do the right rapid diagnostic test. If it is negative, then continue doing other diagnostics for fever, including COVID.
Yeah, that actually reminds me that example you pointed out of a high-ranking politician who actually had gout, and and then he came to you, wanted a specialist like you to treat him of that persistent malaria, actually the resistant malaria, and then taking a blood slide, to him looked like, it's something not to be done by a specialist or something. It was quite interesting drama, that I read in that book, and it's quite educative. How I wish that everybody, who is in the health sector reads this.
Asante sana.
Thank you so much, Professor.
Asante, hamna shida.
Wasalimie wajukuu. Sawa.
Asante.
Bye.
Siku mwema.
Siku mwema na wewe pia.